Hi everyone. Welcome to the first ever PxP India webinar. I'm Maalvika, a psychologist and patient advocate living with Crohn's disease, and I'm super excited to welcome you all to this wonderful session. It is all about patient engagement in research, where patients are just more than partners. Patients will drive the research, they will drive their care, and the session is full of lived experiences on how to shape research and healthcare. So a little bit more background about PxP. PxP India is connected to PxP, a Canada-based international patient-led organization supported by the Canadian Institute of Health Research and the Institute of Musculoskeletal Health and Arthritis. The core of PxP is to empower patients and enable them to engage as partners on health research teams. I'm also super honored to share that I am this year's PxP 2025 steering committee member, where we work together and develop all aspects of this conference. This year, the PxP conference takes place from September 9th to 12th. It's a free event, completely virtual, and it is purely run by patients. So for the first time ever, PxP brings PxP to India. So this session holds this amazing panels of experts to discuss the value of patient engagement in clinical research and at the point of care. You will hear from pioneering patients and experts on how to change the status quo and to empower patients as just beyond their identity as patients. Today's session will have speaker segments, a panel discussion, and Q&A to showcase how patients can convert lived experience into valuable expertise that shapes the research and healthcare process. This webinar is designed for clinical researchers, medical practitioners, patient advocates, and most importantly, patients, so that they can change the power dynamic and empower themselves and become collaborators in research and not just research participants. And I'm also excited to share that PxP India is one of the 3 regional PxP webinars alongside PxP Africa and PxP Australia. So just before we start the session, I would like to share a few housekeeping notes. Please use the Q&A function at the bottom of your screen for if you have any questions for our speakers. The chat function is for you to introduce yourselves, share any resources that you think might be helpful for our panels, for us, or for anybody else that would like to read it. And we would be capturing everything that is shared in the chat so that we can have anonymized summaries for each session. Also, if you see at the bottom of your screen, there's something called closed captioning mentioned. If you click on that, you can choose any language that you would like the session to be translated to in terms of chat. For full bios of our speakers and panelists, please look at the chat. We would be sharing links to our speakers' bios here. And our social media hashtag is PxP 2025. So please feel free to use it on your social media handles if you want to connect or share anything regarding this session. Just a disclaimer, this session is being recorded so that anybody who cannot join can watch it later. A big thanks to the Canadian Institute of Health Research and the Institute of Musculoskeletal Health and Arthritis for supporting this webinar. So as we go along, please keep an eye on the chat. Hetty or Dawn will be sharing links for the PxP conference page and any other information about the steering committee members or anything more about these sessions in general. So I would now pass the session to my colleague, Nikhil. Nikhil is a patient advocate living with Crohn's disease and ileostomy and thyroid cancer. He is also the director of IBD Patient Support Foundation India, where he tirelessly advocates for individuals living with IBD in India. So over to you, Nikhil.
Thank you, Maalvika. Thank you for the introduction and good evening, everyone. Welcome to this PxP India event. And for the next 15 minutes, I'll be talking about patient engagement in health research. So let me just share my screen. So, so we are here to talk about patient engagement, and the theme for this year's event is embracing patient engagement for better clinical outcomes. We have mindfully chosen this theme because patient engagement, what we are talking about here, is patients acting as research partners rather than just research subjects. And as I heard a line in the recording of the PxP Africa event, it's about changing architecture and not just optics. So that's why today we are going to talk about how can patients, clinicians, and health researchers embrace patient engagement so that better outcomes can be achieved for patients and for everyone. So So today we are going to talk about basically I'll be talking about what is patient engagement, what does it look like in practice, what are the pitfalls to avoid, and how can we promote patient engagement in India. So coming to what is patient engagement, the word patient in the term patient engagement does not refer just to a person who's living with a health condition, but also it can be a caregiver, it can be a family person or a close friend. And the term patient engagement refers to a meaningful collaboration with the patient partner so that a variety of perspectives can be explored and various research approaches can be explored that ultimately result in a better healthcare system and better care practices. Finally, patient-oriented research is research where patients are partners, and throughout the research cycle, their input is taken, and they direct the research, and they determine, what the research is for and what are the priorities of the research. There are various organizations which support patient-oriented research, but everyone uses a little bit of different terminology. So in the UK, we have NIHR, which uses the term patient and public involvement. Sorry. And in the US, there's a organization called PCORI, which uses the term patient-centered outcomes. And in Canada, we have SPOR, Strategy for Patient-Oriented Research. It uses the terms patient engagement and patient-oriented outcome. Now, there are various levels of patient engagement. So the lowest level is where there's just a one-way communication from the research team towards the patient partner. So basically, the patient or the patient partner just receives information on what the research is about, and it could be just like a plain language summary. So this is completely a one-way interaction, and there's no feedback taken from the patient partner. When there's feedback taken from the patient partner, and when there's a bidirectional communication, then patient partners can be considered as consultants, and they can give their opinions on various aspects of research. But the ultimate decision, the final decision to whether to use the suggestions or not, that is with the research team. And moving upwards, we have higher and higher levels of patient engagement where the extent of collaboration and communication increases. And at the highest level, we have empowerment where patients can actually determine the research directions and research priorities, and the suggestions given by the patients are put into action by the research team. Now, what are the benefits of patient engagement? Needless to say, having a patient partner on your research team can not only give you more perspectives and can help you explore more research directions, but also the lived experience that they come with and the insights that you can get from the lived experience are incredibly valuable. And of all, the most important benefit is that, especially, and this is especially important in terms of, in terms of illnesses which are complex and a lot of chronic diseases which do not have any cure and the causes are very poorly understood, where when the patient-oriented outcomes become actually very important for patient satisfaction. And there, having a patient partner on your team can help you understand what kind of research is important to the patients and their families, and what kind of research should you pursue, and what kind of outcomes should you be measuring, so that ultimately your research can have actual relevance in the real world, and patients and families can actually benefit from your research. So, how to put this in practice? So, to basically practice patient engagement, there are few kind of values which you must embody, and some of them are inclusiveness, having an inclusive atmosphere where the presence of the patients is acknowledged, where the value of their lived experience is acknowledged, and having a supportive atmosphere in which patients can contribute to the research. Their accommodations are given so that they can contribute in a comfortable way. There's mutual respect, there's no power hierarchy, and there's an attitude to co-create or co-build with the patient, right from the research ideation to implementation and dissemination. The research team should support the growth of the patient partner. A lot of patients may not be well versed with the research process, but it's not that they cannot learn and they cannot learn about the research process. So adequate resources and training materials should be provided so that any patient who's interested in getting involved with the research team can can play their part. Um, and sharing lived experience, whenever a patient shares lived experience, there can be a process of re-traumatizing, because they may have gone through several micro or macro trauma events, and when they share their lived experience, this can result in very strong memories and a trauma response. So it's essential to create a safe and comfortable atmosphere in which they can share their lived experience, and the research team can fully benefit from all the insights that are shared by the patient. Coming to the logistics of participation, there should be a clear draft of the roles and responsibilities of the patient partner, what is expected from them, and a clear description should be given to the patient. A clear timeline should be established, and enough time should be given to the patient to complete the responsibilities. Obviously, the computed time should consider the health condition of the patient and should be accommodating of the health condition of the patient. And when it comes to communication, it's better if the patient's chosen method of communication is utilized. And even though face-to-face meetings are better, they may not always be viable. So the research team definitely needs some flexibility. And a designated person should be there to keep in constant touch with the patient partner, even when there are no updates. Finally, one of the most important parts is compensation, and the patient partners should receive adequate compensation for their work. And this not only includes the compensation for their expertise, it can include the expenses towards their travel, towards their education, towards childcare, towards technology access, etc. So all this requires research teams and medical practitioners to look at research from a different perspective, as an inclusive space where patients are welcomed and their lived experience are welcomed, and accommodations are made so that patients can effectively engage in the process, and the engagement happens in a way that the patients feel comfortable and safe, respected, and an atmosphere of trust and quality is maintained, which will promote effective collaboration. Now, some of the common pitfalls which are kind of natural when you are starting patient engagement, which should be avoided. So first of these are, and most of these come from an assumption that patients are not really made to do research, because so a lot of some of us may think that they do not have a scientific background, and their role in research is limited to a subject. But the main point to remember is that lived experience is as valid as formal training. It's as valuable as formal training, um, because they have been living with the condition for years and years, and the insights they have are, they cannot be found in any textbooks, and they are important. They are important insights that can help determine, effective. That can help with research that is actually valuable in the real world. So. Again, one must respect their contributions, one must respect their lived experience, and a comfortable atmosphere must be made. So a trauma-informed approach is suggested, where we acknowledge that it's difficult to share lived experience, especially when there potentially might be very difficult experiences. It's necessary to offer breaks, support, and gradually build trust, and to also avoid unnecessary pressure for the patient partners to engage or to share beyond a certain level. Now, one of the common things that occurs is tokenism, in which symbolic inclusion happens of the patient, and this is the symbolic inclusion. Plays the part of, basically it's proxy engagement, and you show that, okay, you have included a patient when in fact you have just put them there to just show inclusion. It's not actual inclusion. So that not only erodes trust actually between the patient and the researchers, but also it basically completely defeats the purpose of having a patient partner and having that lived experience insights, and it completely devalues the patient and their whatever they have gone through. and their lived experience. So it's very necessary to avoid this kind of practices, and uh, it's very this kind of practices are actually very rampant in especially in our setting where patient engagement, not everyone is aware about patient engagement. And finally, again, related to tokenism, there is this, it happens because of this, inherently assumed power hierarchy that, patients are below, patients are at the bottom of a pyramid, which includes researchers, doctors, pharmaceuticals, everyone. We are we are like the test subjects. We are basically the customers. We are the source of money, but, and that's all we are, you know, so steps should be taken to minimize this power imbalance. And these are some ways to kind of respectfully address patients and minimize that power imbalances. So when in meetings, you use first names, let patient partners co-chair, and again have a designated point of contact to support their input, encourage their inputs, and this power imbalance should be discussed openly, and solutions should be found by through mutual communication, respectful communication. And disagreements are natural, and these can sometimes be valuable. But the idea to handle these disagreements gracefully is to kind of challenge the ideas, not people, because that would again devalue the patients. Respectfully disagree and have a discussion that is focused on the goals of the research and the shared goals, and try to have a conversation in which you do not disrespect the presence and the lived experience of the patient. If a patient partner wants to leave, that should be possible, and future collaboration should be possible. And this is a realistic event because, again, health conditions are unpredictable. In that case, you should have multiple patient partners to ensure continuity. Where to find them? There are plenty of places, starting with a patient organization, a research network, asking a clinician, health delivery organization, an academic health organization, and finally social media. Now, moving towards patient engagement in India. So, in India, this is a nascent, and this is a very nascent idea, and having patients as partners in research would, again, I think to some it would, kind of sound absurd, and again, that what value will they even bring? But yeah, as we saw, having that lived experience can actually help do more meaningful research that is actually appreciated by patients and their families. So if you are a patient and you want to start, getting engaged in research, so we have to start from the lowest levels and firstly learn to read research papers. There are plenty of online resources available, some from PxP. There are some resources on Cochrane as well, and start discussing research with your healthcare provider, inquire about local research efforts. And a good way to start understanding research is, trying to engage in plain language summaries, trying to write plain language summaries, read plain language summaries, and see how they are made. The next step is to find opportunities and build more capacity. So by learning research terms, methodology, and more as per the interest of the individual. There are a lot of online resources. Again, PXP has a blog where there are a lot of resources. There are a lot of certifications that you can pursue. PACER is one of the certifications that Dr. Pooja, one of our panelists, have started. It's a very excellent initiative. It stands for Patient Advocates for Clinical Education and Research. So that is a very good certification. There's UPATI. And again, talk to your healthcare provider for opportunities. Some small opportunities can be found at Cochrane Engage, Cochrane Crowd. And also, a very good way to spark conversations is to discuss some research ideas that can address some unmet needs of the patients. Finally, we have to advocate for patient engagement and inclusion, as is the purpose of this webinar. It can you can also write comments on research, treatment guidelines, op-eds, very good places, BMJ opinion. We can talk to patient societies, research funding agencies. And finally, we can also point healthcare providers and research teams towards PXP and other resources which help them to adopt patient engagement. Like I said, it's very it's patient engagement in research is actually a very is very nascent, and so towards getting there, we can actually take some small steps, and that is patient engagement at point of care. So at point of that means talking to a healthcare provider about your treatment decisions and practicing what is called shared decision making. So to speak more on this, I invite Clarinda, who is India's first UPATI trained patient expert and a patient engagement consultant based in Mumbai, and she'll be talking more about patient engagement at point of care. Over to you, Clarinda.
Thank you, Nikhil, for that very in-depth and insightful presentation on patient engagement in research. We have a long way to go in India, but I think conversations like this are a great starting point. So I'm just going to share my screen and talk about patient involvement at point of care. Before I start, I just want to remind everyone to feel free to post your questions on the Q&A section, or we'll try and take some of them up in our panel discussion a little later. I hope everyone can see my screen. Um, so I'm going to talk about patient involvement at point of care, and I'll start by sharing my own story. I was 25 when I was diagnosed with a rare disease. This is an AI generated picture that kind of depicts the situation. You see a young girl, woman there with research papers in her hand, and the doctor with a smirk on his face. I was a science communicator. I had lost, I was partially paralyzed in my left arm. My rare disease is called neuromyelitis optica spectrum disorder. Its symptoms are similar to multiple sclerosis. And I was being recommended a drug that would cost me 1 lakh for every dose. And I was expected to take about 12 doses in a year. And I had to be admitted for every infusion. And between infusions, I would have fever. And it looked like my life was over. So I took these research papers and I was asking, but I see treatment options. And I was being completely dismissed by this doctor. And he said, what if I told you you could be blind in a little while? And I left, obviously feeling extremely dejected and afraid. But I decided I'm going to look for another doctor. And then I found the doctor who changed my life. And I don't think he'll mind me mentioning him because he knows the impact that he's had on my life. This is Dr. Rohit Bhatia at AIMS Neurology. I went to him with my stack of research papers, and at AIMS Neurology, for those of you who've been there, with people scrambling at the door and a long line of people outside at the OPD, he sat and he explained my options. He took the research papers, he drew on the whiteboard, he sat with my MRIs, he allowed me to understand all my options, and he put me on an oral medication that costs 100 rupees, still costs 100 rupees for 10 tablets. And that's pretty much what I've been on for the last 15 years, very stably. I have a lot of other complications, but those are besides the point. That was my first experience of shared decision making, and it was also the reason many years later that I became a patient advocate, and because I felt that I wanted to give more patients this opportunity to understand their place in a medical conversation, to understand their right to ask questions, and their opportunity to find a doctor they can connect with who is willing to meet them where they are. So these are real patient voices. These are some quotes from a research paper that I published, where I interviewed a lot of patients with chronic conditions, India-based patients. So it would be extremely difficult for someone who doesn't have any experience with medicine or understanding of terminology to have a decent conversation with this doctor. The doctor would not be upfront about financial implications unless asked. Some doctors proactively talk about this, others don't. I started crying because I couldn't handle it. And then as an afterthought, he said, yeah, I'm sorry, this is bad news. I felt like the doctor doesn't remember the case and we have to remind him every time and ask very specific questions to get the information we need. I want a doctor who takes a little time to explain, one who shows a little empathy. Sometimes the patient knows a little more about their own case than the doctor can from their books and structured medical learning, but doctors don't accept or appreciate this. I'm sure that many of the patients hearing me right now identify with some or many of these statements. You've been there, you've heard this before. So this is for you today. What is patient involvement at point of care? Some synonyms that we use are principles of shared decision making and person-centered care, where treatment is about the patient as much as it is about the science. It's a collaborative process where plans of care are made with patients and not for them. It goes beyond the biology, which is all about the science and the guidelines, and it includes compassion, which is about emotions and empathy. But then it also adds biography, which is the unique life situation, the priorities, and the context of the patient. It requires a combination of careful and kind care, where careful care is based on the best science and tailored to the patient and not a class of patients. So, not all patients with a particular condition, but this particular patient. And kind care is respectful of the fact that the patient, not just the doctor, has limited time, energy, and attention. I should mention that I run a podcast called Not Just Patients, where I've had two excellent conversations about shared decision making. One with a clinician called Dr. Victor Montori, who is an expert in shared decision making, and one with an endometriosis patient advocate and patient called Estelle Jobson. And a lot of my presentation material builds from those conversations and stuff that I've learned from them. So I need to attribute a lot of this material to them. So the values underscored in shared decision making are empathy, honesty, openness, respect, collaboration, information sharing, active listening, ensuring that the patient understands what the doctor is saying, patient autonomy. So it is finally the patient's choice. No power disparity. The patient and the doctor are essentially just people. The only difference is that the doctor has learned something about the thing that they're talking about. But the patient is an expert in something else, in their whatever, their field of work and their field of course, in being a patient. But apart from the fact that they've studied, there's nothing that makes the doctor greater than the patient. And minimally disruptive care, which means that as far as possible, the care fits into the life of the patient. In my conversation with Dr. Montori, he said, have you ever heard a child say what they want to be when they grow up? I want to be a great patient. No. Patients just want to live their lives and they have their careers, their families, and dreams. And health must fit into those lives, not the other way around. So, why patient involvement? It ensures that care plans fit into patients' lives and circumstances. It helps patients and clinicians work as a team against the disease and not doctor versus patient. Once there's more trust, obviously there's less anxiety. It helps patient adherence, which means that if the patient is involved in deciding the care, the patient is more likely to follow that care plan, is more likely to take their medicines, and then is more likely to have the clinical outcomes that are desired. And then obviously it leads to better satisfaction both for the patient and the clinician. So these are some methods of shared decision making. One could be about negotiation and compromise, where the patient and clinician work through conflicting positions. So you need to balance treatment burden versus daily life. One example of this could be late stage oncology. You have a late stage cancer diagnosis. This comes up very often. Do you treat aggressively, and which could mean low quality of life for the remaining period of life and extending life as much as possible, or do you just let the patient live comfortably for whatever life is left. And that completely depends on patient values and preferences. But it is a conflict, it is a negotiation. Um, Choice among options. So this is what I did when I had to evaluate treatment options. I had to evaluate the benefits and harms, and yeah, and then go through different treatment options. Uh, Tailoring. So where you test and adjust treatments. So this happens maybe in some skin conditions where different patients respond differently, or some orthopedic conditions, different patients adjust differently, autoimmune conditions, and you need to try different things at different in different capacities, and then see what works for a patient, and then helping patients make sense of things. This moves a little beyond the clinical consultation domain into counseling, which is something again that is very, very lacking in India, maybe except perhaps in oncology to some extent, but it's really lacking in other chronic diseases, where a clinician directs a patient to someone who can help them make sense of all this. I didn't have it as a 25-year-old who had to figure out what am I going to do with my life now. Challenges in India, doctor is God attitude. Patients really don't know their place to question. They are used to taking green and blue pills in a packet, not even understanding what they are. And doctor said, and they take and they do. Of course, overburden systems and a lack of time. Varying health literacy levels. They don't have the resources. They don't have the skills to even question, to understand what they need to ask. Biases and inequities very often, like I'm sitting here in a room where I can put the AC on in Mumbai and I can talk about asking a doctor. I could take a flight to Delhi and meet a doctor of my choice. A lot of patients don't have this, so I'm very aware of that. And there are huge inequity gaps, where only like patients in urban settings and highly educated patients have this privilege of being a patient partner, as it were, in a clinical setting. And then, of course, the fact that clinicians are not even trained in this. This is not something that is addressed at all in medical school. So there are obviously opportunities for clinicians to see patients in high definition, not as a blur. And this does not need more time. It just needs presence. It needs focus. It needs an intent that yes, this is important to me. It could be small things like asking a patient what is most important to you today. One of my recent podcast conversations, my guest told me that an oncologist asked their patient at the end of the conversation, how can I support you more? And the patient said, I'm really sad because I have to go for a wedding in a couple of weeks, and I've been feeling so tired with my medication that I won't be able to dance. And the oncologist changed their medication for those couple of weeks, and the patient could dance at the wedding. And just imagine the impact of something like that, just that one extra question, which would never have been asked otherwise. But the impact, because there are pictures of that person dancing at the wedding, and for life, like later, that the joy that brings that person. Using plain language, just helping them understand. And one way to do this is to have ready material. You might, for doctors, 80% of the time patients are asking the same questions. It's not difficult now with technology to have ready material, yet to tailor your approach. Not all patients want all the information. And so it's a fine balance, but it's important for the patient to know that they have that choice. And that's where shared decision making comes in. So if the doctor makes themselves available and says, and then it's up to the patient to say, no, doctor, you make all the decisions for me. That's okay. That's still shared decision making. It doesn't mean that the patient has to take charge, but it's important for the doctor to meet them where they are. And offer options allow time to reflect and schedule follow-ups. There are opportunities for patients to prepare before visits, make a list of questions and priorities. Having a structured list helps keep emotions at bay. Ask questions, repeat back what you have understood. Make sure that you feel like you are entitled to that time with the doctor. If you can't play this role, take someone who can. It's okay to be emotional, but take a caregiver and set the expectation with them to say that I won't be able to do this, but this is what I want out of this meeting with the doctor. Actively seek second opinions and doctors who make you feel comfortable. That's your right. And feel free to connect with patient advocacy groups. Look for information, reliable information online and from trusted sources. Equip yourself as much as possible. There are, of course, huge opportunities for the system to incorporate empathy and shared decision making in medical school and continuing medical education. To teach medical self advocacy as a life skill, like from childhood. If we learned this as children, then we would not be talking about power disparities. We would not be talking about whether it's okay to question our doctors, right? If children were taught that yes, it's your body and you should be asking these questions, you should be looking up. Mass media awareness campaigns, just the need to build trust and visibility of patient advocacy groups. We have some amazing patient advocates in this room today, but there is no awareness of them in India. And we have excellent digital penetration, and the power of that is huge in this country, and it should be used to improve health literacy in regional languages. While I've suggested things that patients, I do want to underscore that a disproportionate onus lies with the system and with the clinicians, not on patients. Patients have a very heavy burden to carry already, but the system should be doing more. It should not be that patients have to be so assertive to get care. The system should make it easier for everyone. And that's about it from me. So with that, thank you everyone for listening. I think we can move into our panel discussion. I'd love to welcome all our panelists on screen if you're not already. I need to just change my view so that I can see everybody. I'm just going to take a moment to introduce everyone, and you have your names written, but maybe you can just wave as I call your name out as well. So we have Vachasamrita. We're going to call her Vachas in this session for ease of, just to make sure that we get it right. So hi Vachas. Vachas is the chairperson of Lupus Trust India, and she's going to be bringing in the child patient and the juvenile perspective as well in this session. We have Shruti Gupta, who is the co-founder of Lama 2 India. Shruti is a parent and she is going to bring the rare disease patient perspective. We have Naumika Khanna, who represents several NCDs, diabetes, epilepsy, and mental health. She's a passionate patient advocate. Hi, Naumika, welcome. We have Dr. Pooja Sharma. She wears many hats. She's a gynecologist. She's a clinical research expert. She's the CEO of APAR Health, and she is the project lead of PACER, which is Patient Advocates for Clinical Research. Welcome, Dr. Pooja. It's lovely to have you. And we will have Dr. Suman Karanth joining us in a while. She's a medical oncologist and the additional director in medical oncology at Fortis Hospital. I think it's Fortis Hospital. I hope I got that right. In Gurugram, but I'll check with her when she's here. And Maalvika and I will be conducting this panel discussion. Once again, inviting everyone to feel free to ask questions, and let's make this as interactive as we can.
Thank you. First of all, thank you, Clarinda and Nikhil, for these amazing presentations. I'm sure our attendees have gotten a lot of insight from this. So from Nikhil's presentation, we learned that patient involvement in, what does patient involvement in clinical research looks like, the value of it, and how patients can get involved. All of this is the ideal case. Now let's translate this into the real world. So I would first like to ask Vachas, Shruti, and Naumika, in your interactions with clinicians, researchers, and other non-patient key stakeholders, do you always feel adequately heard? And have you been fairly compensated for your lived experience or your expertise? Maybe Vachas, you could answer this first, then Shruti, and then Naumika.
Hello, everyone. Thank you very much for having me here to the PxP team and Nikhil and everyone here. I think I would like to highlight 4 points. Number one, like we just spoke about the fact that lupus, I can speak for myself. I was diagnosed at 12, but I had symptoms since I was about 9. So that came in the way of being in conventional education and things like that. But to just specifically talk about patient involvement in research, I think when it comes to juvenile cases, it has to be the legal guardians and the caregivers that have to be addressed here. And there's a lot of the caregiver guilt, all of that needs to be really addressed, and they need to be handheld. Yeah. The second thing that I would like to say is I was just discussing with Nikhil the other day the different types of research, and the common notion of research is somebody sitting in the lab probably injecting you. So that has to change, and I think even I need to learn more about it. And I just realized I did not know much about it, despite being in this for the last 10 years. Um, the third thing that I'd like to talk about is same point that both Clarinda and Nikhil mentioned, which is the patient as partner, patient as consultants, where there's no power hierarchy. In the and that results in better clinical outcomes. That is something that is so needed, because I can just say, I can speak for my mom as well. Like, it's after the consultation, she comes back home and asks me the question, and I'm like, Mom, you could have just asked the doctor right there. She's like, but how can I do that? So that's one point. And lastly, I had the privilege of meeting Padma Shri Dr. MRR Rajagopal from Pallium India. And to quote something that he often quotes is that it is the person that suffers, not the body, right? He's the father of Indian palliative care, and I wish we could look at that even more in that sense. Lastly, Dr. K.M. Cherian, who's also known for who passed away this year. I had the privilege of meeting him. He's the father of pediatric cardiothoracic surgery in India. And he just told me the best lessons you will ever learn is from your patients. So this was it was so inspiring for me to see that they have put patients, as their partners, and sometimes even their teachers. So yeah, I think these are the points I'd like to say. And the fact of the matter is, there is nowhere we can go. And if you're not even able to talk to your doctor, forget asking them about research possibilities and where you can participate. So that's one thing. And of course, lastly, I think, Clarinda, you mentioned about how you needed to get an infusion of almost, which costed you 1 lakh rupee per infusion. It happened with me. I needed multiple monoclonal antibody drugs to be imported. And it was a very traumatic experience. Needed 30, 40 of those infusions, the freight charges and everything. So I think the moment that becomes, like you said, you quoted your doctor, Dr. Rohit Bhatia. I was so touched to hear how he took that time to just be there and answer that. That's what we need. Well, I think this is it from my end with regards to this. I think we are nowhere I've not known about what's happening in research in India. I don't even know where to reach out to, and I don't even know how to let. I know patients in our group, about 1,500 of them right now in our organization, who say that I wish doctors could learn something out of my case so nobody else has to go through what I did. And so many of them are so keen in taking part in research, but unfortunately there's no what do you say, a platform for them to reach out and be a part of it. So I think it should start from there. Thanks.
Thank you so much, Vachas, for that. Shruti?
I think majority of the point Vachas has already, mentioned, which is rightly said and quite true. Now that I always say that my rare journey with my child started in last year, which is 2024, right? So I could say that yes, sometimes I do feel that clinicians or the researchers are listening and they are including us while they are trying to do something, but sometimes it feels so tokenistic. So you feel like it's just taken a box and there's no inclusion at all. That's genuine thing which I have faced. And I would like to talk about Dr. Ratnapuri. She's a chairperson, Sir Gangaram Hospital. And the one thing she just told me is that, I'm meeting a second mother who's just after Lama 2. I met one mother who was after SMA, and she was like amazing lady. And then I'm meeting a second mother who just breathes in Lama 2. And we can't be happier. I was like, why are you saying it? And she said, doctors can't work at all if a parent doesn't come out. So, and that gives a boost, right? You really want to work forward to it. So that's a thing which I always say that. As far as compensation is concerned, I am really novice in this area. So I have not experienced that to be true, right? And for me, right now, it doesn't exist. Maybe sooner, once I'll be more into it, because I'm hardly a year old, not even a year old. So I'll learn it sooner and later. So that's it from my end. Thank you.
Thank you, Shruti. Thank you for being so candid about your experience. Naumika, would you like to add to this?
Absolutely. First of all, thank you for asking this question. It's not a question that's, asked very randomly. Second of all, Don or Hetty, could you present the slide that I'll be talking about so that I can substantiate my answers? So first point is basically this, that when you live with not one but many chronic illnesses at hand, every day becomes both a battle as well as a lesson. And often I would suggest a gamble. Some days would shine like sunlight in spring, while others would feel like thunderstorms. When I took a look at these conditions such as diabetes and epilepsy, I often feel what Khalil Gibran often said. The reality of the other person lies not in what he reveals to you, but actually what he cannot reveal to you. Actually, having type 1 diabetes at the age of 7 taught me responsibility even before I know what the word meant. And when I was just learning to carry the weight of diabetes, epilepsy struck me like a lightning bolt at 15. And suddenly, I was not just counting the carbohydrates, I was also counting the seizures and the stigma which I faced from the society. For a long time, I kind of felt invisible in the healthcare system. And just as we were mentioning ethics, like Nikhil was mentioning, doctors would say that we know what's the best for you. And as Clarinda was mentioning, especially that I also faced that when I underwent a neurosurgery at 23 years of age, I was asked to just brush through the informed consent of the surgery, but I often wanted to whisper back, let me read it, because no one knows what it feels to live inside this body except me. And that's why patient engagement in research is extremely important. For too long, research has been something that is done on the patients, not with the patients as partners. Yes, data, trials, and numbers as projected, they are extremely important. But data without the importance of lived experience is like a map without the terrain. You may know the direction, but you will miss out the obstacles, the shortcuts, and the lived human reality. So let me share few examples. For example, I met a woman who also had epilepsy. She told me it's not the seizures that kind of break me or scare me. It's losing my job, my sense of identity, and the stigma and the stares which I get from the society, and the discrimination that often makes me feel unself in the society. This is from the underprivileged part of the India that I work, and this data too is what we rarely measure. So, just as others mentioned, the impact of caregiver burden. My mother often says to me, your seizures may happen to you, Naumika, but they often live in my heart. Behind every patient is a caregiver who is having financial strain, silent fears, and their stories also need to be represented, not ignored. That is why patient engagement is very important, because it shifts not just the medical model of the disease, but rather takes into the view the biopsychosocial model, which is the holistic model, where mind, body, as well as the role of the community, like all of us are mentioning right now here, in simple words, I'll mention, are actually part of the whole picture. So, when patients and caregivers learn to co create the research questions, we not only study the illnesses, we are studying the lives, the emotions. As a psychology student, I would like to say that is what the true is meant to serve. So think of it as the difference when patients are heard. I would like to, give an example, because I never talk without examples. For example, a researcher might design the most advanced insulin pump, which many of the type 1 diabetics use. My friend uses it, but he may not know the efficacy of the pump unless the student or the child says that it's too heavy for me to play football with my friends. Or a neurologist could prescribe the most effective anti-epileptic drug unless the patient says, who is a student, that it makes me feel too drowsy to sit for the exams. That is the value of patient engagement. It kind of bridges the gap between the science and the humanity aspect. Last but not the least, I would just like to finish it off. We should reimagine patients not as a part of a pyramid with them lying at the bottom, but rather a circle where every clinician, patient, policymaker, healthcare stands side by side, hand in hand, sharing power, knowledge, and responsibility. Because it's rightly said that change will never happen in isolation. And research without patience would be incomplete. Care without compassion is ineffective. Systems without partnership, as all of our PPTs are mentioning, are unjust. We are not just participants, rather, we are experts in our own lived experience, which includes me too. And we bridge the knowledge of what it means to inject a insulin injection in a school bathroom, to hide a seizure from classmates, sometimes from family as well, to carry those scars that no one else except the person living with chronic illness can decipher, honestly. So that is what shared knowledge and healthcare is known. And I think I'm so grateful that I would just like to sum it up by saying that this is what for patients, by patients, and considering patients as partners has done today, which is honestly just monumental. And I would say my illness just gave me scars, but they also gave me a voice for the voiceless. And today, that voice insists on being heard, not being on the sidelines, but actually at the podium, at the expertise, at the center of research and cure, with the ethics in mind. Thank you.
Thank you, Naumika and Vachas and Shruti. You all brought in such diverse and very, very insightful, thought-provoking perspectives on that. I'd like to get a little bit disease specific and talk about research when it comes to your own diseases. Naumika, you touched upon it a little bit, but I'd like to understand, when it comes to, so Vachas, for example, what would research involvement in patient involvement in research mean for your community, like the lupus community or say the autoimmune disease community in India? And maybe here's where you can also bring in the perspective of children and child involvement in research and the role that parents would play in that scenario.
Right. Yes, Clarinda, I would like to just reinstate what Naumika said. Like in a multidisciplinary illness where you are sort of oscillating between your primary diagnosis versus the pain and the symptoms that come because of the diagnosis, then the treatment related pain, and then the comorbidity related pain, and then it's a giant mess. It's a painful mess, and patients are caught in that chaos trying to differentiate what is what to even tell the doctor, what we weighing out things that maybe this may not be significant enough to tell, and things like that. I think when it comes to multidisciplinary illnesses like lupus, because at one given point, 3 or 4 of my organs were at stake. And so what I think is there has to be almost compulsive level of documentation, which means documenting every nitty-gritty, so that the doctors are able to, and the team of researchers are able to distinguish what symptom is from where, and just etiology, basic disease etiology to some degree. And I feel as long as that's not going to be done, um, we will be talking in euphemisms, and it's going to be a very gray space that will take us nowhere. So I think when it comes to lupus, considering how it is aggressive, especially in children and up to the age 22, 25 or so. I'm 25 now, and lupus has been a little kinder on me. But however, I'm paying huge price for the 10 years of immunosuppression I've been on, every month of IVIG. I probably finished 55 doses of IVIG now. So, yeah, I think documentation would be the right system for data management, data structuring, and then eventually some sort of triangulation and further study is where I think it has to start with. Thank you.
Yeah, thank you. I completely hear you on the comorbidities front, and the fact that there is nobody looking at us, like one doctor sending you to the other discipline, one discipline sending you to the other discipline, and
Yeah, it
nobody
reminds
really.
me of that Spider-Man meme where there's this New York, police department where one is pointing at the other and others pointing at the other, which is the primary physician versus specialist, game that's going on. Yeah.
Okay, thank you for that. Shruti, like you, I'm a rare disease advocate. We know the challenges for rare disease research are extremely different, unique. There is so little because there are such few of us. Can you talk a little bit about some of those challenges from your perspective?
Uh, so what I would say is when Ishika, my daughter, she got diagnosed, right? The genetic report says Lama 2 MD, and we were not even aware of the word what does MD means. So we quickly Googled what does that mean, and it says muscular dystrophy. And we're like, okay, it's okay. We'll see what we can do. And then we went to doctors, and what did they say? They just put a hand on our shoulder and they said, just live a life whatever you had with the child. I was like, what are you saying? She's like, there's no cure, there are no patients, you won't find a patient. It happens in 1 or 2 patients in 10 lakhs of kids or children, right? In India, in Delhi, I'm pretty sure in Delhi for sure there'll be no patients. It's like, okay, that's where the journey started, right? Because we are the working professionals and we take a project on a very head on way that no, we should do something, because there's no awareness at all. Even if you'll Google muscular dystrophy for now, no, you'll get to see ancient, maybe like 5 years or 7 years or 10 years old of pictures coming up on Google. I was like, okay. And that's when we started this Lama 2 India. So now that the ranking is going well for Lama 2 India, the moment people sees that, okay, this is muscular dystrophy, and there are variety of muscular dystrophies, and it's not only limited to SMA or DMD, because people are now hearing it as a buzzword because we have at least a gene therapy coming up. But for other diseases like Lama 2, yes, research is actually happening outside India, but nothing is happening in India. We tried contacting people. And there are no patients, Shruti, there are no funding. What should we do? You bring out the patients. And that's when we started out that there's a Japanese company who's doing a research on this particular disease. And I used to send out an email to the CEO of that company that, hey, I'm from India and I've gathered 5 patients. And hey, I'm from India, I've gathered 10 patients. And that's how my journey started. And the moment I touched 30 patients, and I said, why don't you do the clinical trial in India? He's like, you guys would be able to arrange the funds. Like, we can talk to the ministry, we can see what we can do, but at least give it a shot, right? And I think what I could say is that that's a very famous quote, which I would really like people to understand for us, which Clarinda, you said that we are here, please listen to us, please see us, that desperation, right? That
Yeah.
common world, just follow the map. And we have the power to rewrite it or redraw it. And that's when we
Right.
felt it. And I felt it that, with 60 patients right now, I'm just dying to somewhere I don't want the more patients, but somewhere I want more patients, right? So that thing keeps on happening, daily struggle, daily realities doctors are not aware of at all. They're like, they'll be like tube feeding. And I said, ki ma'am, that doesn't happen in all the children, right? It varies from children to children. So the daily realities, a lot of doctors are not aware of because there's no awareness at all. So we tried to put a lot of things on our social media, on our account, so that people start getting some insights and have better visibility, and we'll have awareness around it.
Thank you,
Thank
Shruti.
you. Thank you so much, Shruti. Now I would like to move to Dr. Pooja. So, Dr. Pooja, you've been a clinical researcher and lead efforts to involve patients more actively in clinical research. But why is this not happening enough in India today? What are the barriers and what are the opportunities that we are missing out?
So, Malvika, I'm hearing such, interesting perspectives, and I've been hearing these since even Nikhil started talking. I'm hearing this for the last 20 years. But let me take you back because I'm a little older. Let me take you back, say, 30, 35 years. India is the most populous country today. And clinical trials is something that should be happening in India all around. Why is it not happening? So the narrative started some 20, 25 years back when we started thinking we are going to be guinea pigs. So this, newspaper article was there, this Time magazine cover was there talking about patients being made guinea pigs, especially in developing countries. This narrative took in so strongly that many patients, and I'm a clinical researcher, it's very difficult to convince people to talk and participate in clinical research. Now, seeing the flip side of this change happen actually during COVID, when the vaccine trials started happening, a lot of people started actually volunteering for clinical trials, right? The narrative on news and media started changing. The story was changing and people started participating in clinical trials. Now, while you're saying, there is conversation gaps, but like I'm seeing 20 people over here and 50 people attending, similarly, when I sit on a panel in a clinical research forum, I have the same 50 people sitting from the clinical research side, the clinician side, who actually want to engage with patients, who do not know how to do it. Like there is a gap between the language the patients speak and the doctors speak. Similarly, the doctors feel there is a gap between what the patient speaks and the doctor speaks because we have a particular training, right? It's something that how we've learned and what our training pattern is. Now, in the last, actually, an effort to pacer started almost 15 years back, but really momentum caught on last 2 years. And so 15 years, we kept attempting, there were small fires and it would go out. In the last 2 years, I've really seen the change happening. I'm seeing groups like this come up. I'm seeing, engagement from the UParty teams. I'm seeing engagement from PCORI. I'm seeing engagement in ISCR in India. I'm seeing engagement beyond what you've said is tokenism, right? So PACER, when it started, let me tell you, in the 2 years, what it has done, and the report for which is available for you in the link in case anybody wants to see. Please do feel free to connect with me also on LinkedIn so we can talk a little more in case any other group is interested. So we are currently working with 30 plus patient advocacy groups, and this is agnostic to disease. So there are multiple myeloma groups, there are rare disease groups, there's diabetes groups, childhood cancer groups, and all others. Now, childhood cancer being closest to my heart because I've been volunteering with childhood cancer for 15 years. Let me share with you how that organization grew with the concept of helping out in, using research to create advocacy. Now, all of you are advocacy organizations, and the end product is to advocate for whatever disease you are representing. Same thing was being done by CanKids, but sadly the data was not there. Whenever you go to speak to a clinician or to a regulatory person, they need some data. So let me tell you, with CanKids, what we've been able to do is that we've promoted patient-led research, and I see a few of our patient-led researchers are there in this group who are participating as well. We've done research on access to care. We've done gender bias to care. We've done access to clinical trials, usage of the patient experience of using Clinical Trial Registry of India, which is currently the only way you can access clinical trials in India, to actually document that in a language that doctors can understand, the regulators can understand. We've done cost of care studies. We've gender bias in studies. We've started sitting, actually defining research agendas, sitting with clinicians, sitting with data experts. There is a meeting that is done on data quality, and this was actually being driven by University of Chicago. There was patient representatives sitting there with the Indian clinicians. Sadly, it required University of Chicago to get us together. Like we've got PxP here to get us together. We need to find that courage among ourselves, right? So anyway, India is a massive country. There is an immense amount of data, immense amount of people, immense amount of problems. But things have started. Patient advocates are now participating in ethics committees. I would request all of you, please join PACER to learn about research, learn about so that you can speak in the language of the researchers. Sit on an ethics committee, present your point of view whenever a protocol is being presented, right, or being discussed. Importantly, the language of conversation. So to train patients in the language of researchers, we've put up modules of learning, and we hope to create expert patients. But also we want researchers to hear the language of patients and their point of view and really become patient-centric researchers. And towards that, we've actually, so the survey that you were, actually informally Clarinda was doing with everybody saying, what would you like to hear from your research team or your clinician? Are you able to connect with them? So the clinicians actually feel they are very open. They don't think that they are being closed to you. They think they should have asked. I would have told them, right? So we are actually going to do this exactly as a survey, and we are going to present this in a meeting on the 20th of September, in which we are conducting the same. And I will request one of our, the person who's running the program, Khushbu, she's there on the group. She'll probably collect with you all. We'll send you out a survey saying, how do you think research is being done right now? Can you talk to your doctor about research? And we're going to do the same thing with the doctors, and let's see what they think. So and I'm sure there's going to be a sea change of what they think is happening as a perspective and point of view is a big, big problem. Somebody spoke, I'm not able to recollect, on data. Data is the story, right? And especially with rare diseases, it is a very, very critical story, right? Even with childhood cancer, what was happening was that the child was going one place, usko kuch medicines, treatments mil jate the, and then next place and some investigations, then they were repeated because they didn't know what the reports were, etc. So actually with PCRI, we've created, or at CanKids, we've created this patient passport. It's like a DigiLocker. The patient carries his reports with him wherever he goes. It automatically gets added to his DigiLocker, sort of, but it's created only for CanKids childhood cancer. It's called the patient passport. That is a study that we've also done. So it is all possible, I think, when researchers sit down with patients and start that conversation in a language that's, sort of clearer to all of us. I will just give you two examples and I will stop there. Is the rare disease mothers, the Bharat MD group. I think I just met them recently and I've been highly impressed with them. These ladies have created their own registry, like Shruti is trying to do, so that, there is, whenever the trial comes to India, or they can speak about that trial to, the regulators and the powers that be and bring that trial to India. They are the women who will bring the trial to India. You have to understand from the company's point of view also, it's not an easy task to bring it to two patients. Although I must share the experience of Vivek and Kusum Tomar. I don't know how many of you know them, but Kusum had a rare kind of lung cancer and Vivek got 3 clinical trials for her, just for her, to India. Right? So he was able to canvass because, he knew the system. He came from clinical research background. So now I come from a clinical research background. Suman comes from a clinical background and a research background. I think when we meet together, a lot of things can happen. So I'm really glad, and I'm going to end with, one thing. So PageSir is an effort to create a conscious and aware research environment with healthcare solutions becoming more and more, patient-centric. So joining, hands together is probably the only way. So I'm going to end with what my team has told me to say is research mein bhagidari swasth bharat ki zimmedari. So it is not just me. Everybody who wants to be healthy should participate in research. It's not only when I'm sick should I participate in research. I should speak for research even when I am well. I don't have a lived experience and I don't have a story to tell like the emotional stories you do. But if I do not stand, nobody else will stand. So one person can make a difference. Please have your colleagues, friends who are well to also join this effort. Right. So that's it from my side. Thank you, guys. Thank you for the time, Clarinda.
Thank you, Dr. Pooja. That's like all sounding so promising, and it's also lovely to have somebody who's seen the trajectory and seen the evolution, and yeah, can speak to how far we've come, because otherwise it can all sound quite bleak. And like, this is where we are and we have such a long way to go. But thank you for that pep talk. I'd like to move on to Dr. Suman. Welcome, Dr. Suman. It's really lovely to have you here, and it's great to have one of those. I've had the privilege to hear from you before in another forum, and I see you as one of those special clinicians who really centers the patient, who works a lot with patient advocates. And you work in oncology, which again is a field where there's a lot that is based on patient preferences. Treatment is highly customizable, and so maybe you can just tell us how you incorporate shared decision making in your practice. How you tailor it, and yeah, any doctors who are listening in here, as well as any tips that you have for patients on how to run those conversations with their doctors.
So I was just listening to everyone. I was listening to Dr. Pooja ma'am as well, how she was saying, when patients come, oncology patients come, already cancer is not a very nice diagnosis to have, and it creates a lot of havoc in the mind. So decisions are very complex, because from understanding what type of cancer it is, to what stage, to grade, and now there is a lot of newer things called precision oncology, where you decide the treatment precisely for that particular patient. There's absolutely so much of information being bombarded to the patient. At times, it's very overwhelming for the patient that they're absolutely numb. They are not able to, actually participate in decision making, because they're just listening and nothing is actually getting processed. See, it is very important first to understand how much they understand about their disease. Now, having said that, not everybody wants to understand about their disease. And this can be educated people versus it can be uneducated people as well. You will be surprised how many educated people don't want to listen to what they're having. They don't want to know the stage. Many people want to listen to what they want to hear, that I will get better. Now, while we always say that a patient will get better, we cannot give them false promises. And it is important to give them the right amount of courage to go ahead with the treatment, but not oversell it that they feel that they're going to be perfectly fine, especially at the advanced stages. So what I do is, first I generally give them the information. I check what they understand. My perspective of information, what I give to them and what they understand, is totally different. I ask them to explain back to me what have they understood. Some of them say, you know what, I don't want to know anything. Then I just stop telling about them, and then I speak to some reliable relative who will, then finally take the decision for the patient. You have to understand, in India, the patient is always not always the decision maker. They will decide to be a decision maker if they want to be a part of it. Now, my goal when I explain to the patient is, I ask them, and especially if they want to be a part of it, what is their goal of treatment? Do they want less toxicities? Is their hair very important to them? Things like quality of life. Some patients are brave enough to say, okay, how long do I have to live? Because I want to set my things in order. Some people say no, do everything possible. Some people say no, just let me be. So each patient is different. Many a times, see, we also as doctors are we are also human. And when you have to really counsel people, you need a lot of time, and it's not always possible in a busy clinic. That is where, as Dr. Pooja ma'am said, that is where the patient advocates come in. Because we give so much of jargon to the patients, they may not necessarily understand. They may not necessarily believe that they're going to get better, which they'll probably understand better when somebody else explains to them, gives them real life experience, examples. More likely to believe and relate to the patient advocacy groups rather than us. I always gauge how much the patient, really understands in terms of mental health, in terms of nutrition. Somebody actually mentioned that about nutrition. I think Shruti said about problems that patients face regarding feeding and all of that. See, as Pooja ma'am said, sometimes people don't ask the doctor things. We assume that patients know things. We assume. So we honestly never tell the patients not to ask us anything. We say, you ask anything, but always that neighbor is asked more than the doctor. And they come to the hospital, they forget all their questions. So many a times I tell patients, please write down your questions, ask us. Don't ask that neighbor auntie whether sugar is good for you or not, or whether I should have alkaline diet or acidic diet or whatever. So it's very complex. It is not very easy to get across a message to patients at times. And that is where I think the role of patient advocacy groups are very important. And now it becomes a responsibility of the patient advocacy groups to have the right information. They cannot be going and disseminating whatever they think is right. So that is where they have to work very closely with the doctor, give the right information to the patients, and you cannot oversell or undersell something. You have to give them the right information in the language that they understand. And definitely, as Dr. Pooja ma'am said, we have a huge volume of patients. Everybody has a role to play in research. Like ma'am said, even a normal person should participate in research. For example, when we are doing, now we are actually doing a clinical trial where we're looking at a blood test that will detect early markers for cancer. Now, some normal people like you and me who don't have cancer today, God forbid we ever get it. If we don't give our samples, how will we develop a test? So more and more people should participate for us to differentiate between and to find those markers which are actually going to tell us that this is an early cancer. So everybody has a role to play, and at the end of the day, I think everybody's role is important. That's what I would have to say.
Thank you so much, Dr. Suman. That was really insightful for us to know. Yes, Dr. Pooja.
So, Maalvika, just adding to Suman's thought, is that I was at the ethics committee of the National Brain Research Center just last 2 days back. and they were wanting to do some testing for Parkinson's, and they wanted to do some imaging tests for Parkinson's and Alzheimer's. Now they needed some normal patients also, to normal people to compare. It's very difficult for them to get normal people to volunteer, and all those guys have to come and do sit in a functional MRI, but people are scared. So awareness has to go even beyond the patient. Public has to understand. In the US, 80% of children with childhood cancer will be on some clinical research protocol or the other, even if it's a real world evidence protocol, right? But in India, not 1%, 2%. Those who are at AIMS might be on research protocols. So it's not that Indian researchers cannot do and patients are not there. It's just that there is this gap. And events like this are, I think, the most important way to get that message across. I will definitely share this with all my doctor friends so that this information is heard by them later.
Yeah, ma'am, it's they don't participate. They think we're experimenting on them, so they just
Yeah.
don't come forward. And in the US, we had one of the NGS, the CMO of the NGS group, Garden Group. He was saying he actively participates with the patient support groups and actively educates them to go to the communities and actually tell them about research. So I think there's a huge responsibility over the patient advocacy groups on proponents of getting patients involved to it's not us. It cannot come from us, because if it comes from us, then we are either driven, they feel that we're either driven, publish a paper, or we are research we just want our name out, and we're making guinea pigs of people. So it's very important. So what he does is he educates them and they disseminate the information. It's already proven. Clinical trials improve your survival. And like Pooja ma'am said, every patient abroad, the first thing they ask is there a clinical research available? I'd like to be a part of it. Here, they think, oh, Doc Saab, you are experimenting on us. So you have to understand, doctors are scared to suggest also, So it's very difficult to gauge the mindset of patients unless you've seen them 2-3 times. And it's very easy to get a bad name. So you have to see us, you have to see on the other side, we work very hard to reach where we are, and one bad, Google review, and then that's it. So I think that it's the responsibility of all of you probably to get more people involved.
Definitely, I think what Dr. Pooja and Dr. Suman, the two of you have stressed on, I think that's extremely important. And here's looking forward to a big change in the patient engagement field in research. I would now like all our patient experts here, Vachasamrita, Shruti, and Naumika, to share any final thoughts and reflections that you would like some takeaway you would like our audience to, go ahead with after this conference.
Do I go first?
Yeah, Vachasamrita.
Okay, yeah. I think I'd just like to wrap by saying that, wow, I got so much perspective on what the international scene is, also from doctor's perspective, from Dr. Suman and Dr. Pooja. Wow, it was absolutely fresh information. So thank you for that. I think my request would be like the immediate call to action that, I would request for is if we can have a joint authored document which just says research participation for dummies, a basic guidelines, that would be nice, because I do not know where to go to myself. I was supposed to go to Germany for the CAR T cell therapy for the phase 2 for lupus. It was just not, it didn't happen, of course, but it was a terrible experience. So I really hope that we can actually lay some guidelines down and bust some myths, like Dr. Suman said, that they shouldn't feel like they're being tested on. And in fact, I've heard doctors who have told me once, since I've been on multiple this cocktail of mAbs, from rituximab to belimumab to obinutuzumab and all these bunch of mAbs, unpronounceable mAbs. I was told that you're a guinea pig for your doctor and team. So I think that has to be, taken care of. And I think this guideline, this 10-page document or a 20-page one, extremely simple, would really do us a lot of good. That way we can share that with each of our patient groups. Yeah, that's it. Thank you.
So while what just said this, let me say that we are already making a website for PACER and we are putting out the FAQs. We are creating small videos, and I will request Khushbu or Adarsh, if they are there, to actually put that link there. This is on Clinical Trial Research Registry of India, how to navigate it, and about drug safety, how to report drug safety. So those are two videos we've already created, and we are creating as many as we can. We would love to hear your inputs on what more should we put. So
Right,
I will
Dr.
share
Pooja,
a
because you
draft
just
of that.
mentioned, yeah, you just mentioned about like the ethics committee, the learning modules, and all of that. And I was
All
just
that we are going
grand
to put
going
on
to patient.
YouTube now. So
Excellent.
Clarinda and I have had this conversation, and she's helping us out a little bit with creating a patient perspective in that, in case we've missed it. And we should launch it probably in another 15 days.
Awesome.
Very much needed.
Thank you.
So, a few takeaways would be that coming from the field of psychology, I do get all of your ideas. Some of you are mentioning about ethics, some of you are mentioning about your terrible experiences of being a person with chronic illness. Second of all, that I would like to just mention would be the importance of patient engagement, like we just had today, and you know, uh, what we stand for patients, by patients, giving them the opportunity of being the partners, also addressing some of the, caregiver concerns. And a lot of people were like addressing the stigma and discrimination, which I felt was wrong by the society. The society should be sensitized in a proper manner so that we can move ahead in a productive way. A lot of you said that research is, very centric. There are patients, there are diseases, but there are not normal people who are participating. By sensitizing them, we can actually make them more engaging. And today's session was about this only, for patients, by patients. Thank you.
Thank you, Naumika. Shruti?
The last thing, Dr. Suman has actually given us the perspective which we would really like to put in the words. And Dr. Pooja, wow, what energy you bring on the table. So thank you so much for that, because I agree, right? You literally gave what we really want to share with everybody, that doctors are struggling with what patients are saying, and patients are struggling what doctors are saying, and eventually everybody is confused at what needs to be done, and people are not doing things. And then there are few people who really want to just waken up everybody to come forward and do something. One of the very good doctor, the scientist from ICMR, once told me uh, that stop considering you or your child as a guinea pig. I just hate this word. Just remove this word from the dictionary, because the moment you'll get to hear a clinical trial in US happening, first thing you people are going to do is just register yourself. You're ready to take the citizenship of that particular country, and you're like done. What about India? Just wake up, guys. It's like, okay, ma'am, allow me to sink in this first, that we are in the rare world now. So first of all, I'm going to take the energy of these doctors, because that's a very much needed for us. And second, definitely Dr. Pooja, which Vachas also mentioned, and Dr. Pooja is saying that we are going to roll out in next 15 days. Very good thing, because clinical trial registry must be there in India. In fact, on lama2india.com, I thought of doing that way, that I can call up other patients also, that in case you're very much inclined, just register with us. We'll send you to the patient advocate groups, and we'll try to get you connected with the doctors. So that's also one thing we are also trying to do. So yes, I agree, we can have another round of discussion once we have some concrete plans in place, and we would really like to discuss and connect further on that. Thank you so much.
Thank you so much, Shruti. I think it was really great.
Thank you so much, all our wonderful panelists. And in the interest of time, we're only going to take one audience question. Um, I'm torn because there are quite a few and there are some lovely ones, but I think I'm going to ask Dr. Pooja for patients from tier 2 and tier 3 cities who might not be as educated or confident in their medical language. How can the system ensure that their voices and experiences are heard not just at point of care but also amplified, and that they can contribute to research?
Clarinda, I strongly believe that we underestimate our tier 2 and tier 3. Today morning, I have met Mr. Manoj, I think his name was. He was a very, very dynamic gentleman. And he was from the tier 2 and tier 3. I think I saw him on the chat as well. So tier 2 and tier 3 are they know the disease, they know their problems. Nobody else knows their problems. The lived experience is theirs, right? Second, I think, if India can adapt PayTM so quickly, they can adapt to anything. Right? So if people can pick up technology so fast, when it's relevant to them, they will learn it. Right? In case of Can Kids, and I've seen Can Kids is a childhood cancer initiative pan India. There are children who are from lower socioeconomic status, but they know their questions, they know their problems. They know how to ask the question. You just need to provide them the right people. India has many languages, that is the issue. But if we can make a simplified, currently what we are trying to do is probably English only, but we are trying to keep it simpler language. So I'm hoping that, as many people will come forward to translate this. At the rare disease meeting, I met this dynamic gentleman, Syed something, I forget his name, but he was wanting to do this for the south of India. He wanted to translate and create a registry for southern Indian states because there is a difference totally in the language. At least North India, Hindi, English, samajh lega. So it is happening. India is a big country. All of us will have to stand together and work really hard to make it happen.
Naumika, I'll come to you, but just before that, I'd like the audience to give us a thumbs up if you would like us to continue for a few more minutes. We are at time, but if you'd like us to take a few more questions, then give us a thumbs up if you're willing to stay on for a few more minutes.
Looks like a lot of thumbs up. So
All
that's
right.
great.
So, and panelists, I don't want to take your time for granted. Are you all okay? Okay, super. Naumika, please.
Yeah. So, as Dr. Pooja mentioned, that if they can take on the importance of Paytm and social media, they can take on a lot of other things. I do believe in that perspective, but I would just like to add a little bit more from my side. Since I work from, at the grassroots level, tier 3, underprivileged ones, those who are not at the very good strata level, those who are not earning well, I would also like to say that, what things happen for them, patient advocates, they need uh, to be the, main process, like the main bridging gap, basically. So that, sometimes patients are not able to decipher or even know about the laws, such as the RPWD Act and even the ethics. Uh, um, that is there. And so patient advocates should be the gap so that they can explain in layman language and of course inculcate the importance of ethics. They can inculcate the importance of congruency and unconditional positive regard, because that is what most of our population needs right now, especially taking into consideration the Indian context and the underprivileged strata that most of the India lies, honestly, I would like to say. Thank you.
Thank you so much, Naumika. I do realize, Shruti, that you have to leave. So I would like to thank you so much for being a part of this amazing discussion. I think a caregiver's perspective was supremely important. So thank you so much for sharing your insights here.
Thank you, everybody. Thanks. See you. Bye.
See you. So just keeping in mind of time, I think we can take one more question. Clarinda, you can feel free to ask one more question of your choice because not a lot of us can stay on longer
Yeah.
than this. So,
All right. So I will ask, is Dr. Suman around or has she left? She's left. Um, hmm, this is tough. Um,
Maybe we
so
can take the
there,
publishing question.
Yeah,
yeah,
there
there
I
is a
think
are
question
that
on
might be.
publishing, and I do have an opinion on that. So there's a question on publishing as a patient isn't easy, and it often needs supportive journals and guidance and a lot of help from the healthcare system. What can institutions and professionals do to make it easier for patient voices and experiences to be published and recognized alongside scientific research? I have some experience with this. Before I became a patient advocate, my career was in scientific publishing, and I am more aware than anybody that the publishing world is quite exclusive. And while it is opening its doors a little bit to patient partners and patients as publication authors, it is not easy. I have published a paper as a single author, as a patient author, but I even struggled with things like not having an academic affiliation, not being able to find, to be able to enter my publication on the journal system. There was no place for me it's difficult without having an academic affiliation. For example, the journal editor had to work with me, and it was a very accommodating journal editor because they wanted that patient publication. So there are hoops to jump through, I will admit, but there is progress. There are journals like the BMJ that are very actively supporting patient partnership. Um, there is Current Medical Research and Opinion, which has a section where they invite patient perspectives. They have a patient perspective section. There are certain journals that are doing it more actively, and there are a lot of research groups, also clinical research and other research groups that are actively, happily involving patients as co-authors. And so once you are attached to a research group that's part of an academic institution, then it's much easier to get published as a patient. It's much more difficult to do it by yourself, except as an opinion piece and things like that. But the truth is, yes, there is more openness than there ever was before. And Pooja, you can comment as well.
So what you've said is perfectly right, Clarinda. Things though are changing a lot. Researchers are being accepted in publications, and I really, really love the idea of actually preprints. I've realized that if you don't have the comfort of yet publishing full in a peer-reviewed journal, let's start with some preprints. Also, they are free of cost, so there is no real cost to bear. Otherwise, in a publication house, you may actually have a cost to bear. So people should start writing, put out in the newspaper. At Pacer, we are putting in our local newspaper also. Everywhere. Message is not only there. Message can go anywhere.
Yeah, that's true. That's true. And yeah, that's actually an interesting point, because it's true that there is a different value to publishing in a journal, and that is received differently by researchers. But the point about getting your message out, there's a whole different economy of scale, right? When you use other channels, you can use blogs, you can use
You're doing
Instagram,
it so beautifully.
you can use it in like so many different channels. So there's no limit to using your voice. But yeah, publishing in journals is a different thing. Yeah. So are we ready to wrap up?
yeah, I think thank you so much, all of you, for being amazing panelists. I think all of us have learned so much from this session. So truly grateful for all of your presence here and our amazing audience for sticking on longer with us. I'll now pass the session to Nikhil to just wrap the whole conference up. Over to you, Nikhil.
Thanks, Malvika. So, yeah, thank you everyone for sharing your views and I think we had a really great discussion. There were a lot of points, I think, which were discussed. So I'll just, I think, stress on 2, 3 points. I think one of the points which I felt was that I think a lot more communication is needed. And I think patient advocacy groups do have a very significant role to play to increase the amount of patient engagement in research and at point of care. And I also think that research teams and patient advocacy groups can't do without the support of healthcare practitioners and research teams. So I think everyone has a role to play at the table, and like we talked about, I think with mutual respect and acknowledging each other's role, we can definitely move this ahead and bring make it a reality. And as already told by Pooja ma'am, Pacer is doing a lot, and we at IBD India also have taken this initiative ever since we came to learn about PxP. So, I think a lot of us are living with very complex conditions, and so that's why we consider patient engagement in research a big priority for our organization. We are very, very grateful for the support of PxP and the Canada Institutes of Health Research who have supported this PxP India webinar. And it has been, like a great inclusion and a great discussion. So finally, PxP India was one of 3 regional webinars. There's PxP Africa, PxP Australia. I invite everyone to watch those discussions as well, as there were very good points that we could learn from those as well. And finally, PxP Global is happening on September 9th to 12th. It's a virtual free conference for everyone, and it's targeted for patients and patient partners to be more to engage in health research. And PxP Global Conference was the one event that actually motivated us at IBD India to get in touch with PxP and bring this topic and conduct this event here. And so we have shared the link about PxP in the chat. Please go there. And there are a lot of resources regarding research involvement and regarding how to read a research paper, how to get involved in research. The PxP blog is actually a great trove of resources. So I encourage everyone to visit the PxP website, register for the PxP Global Conference. And finally, a thank you to everyone for joining us today, giving us your time, sharing expertise, and a big thank you to PxP and the Canada Institutes of Health Research for making this event possible and supporting us and encouraging us, and also for our people from who are some people from our organization might be here. So Maalvika is a part of the steering committee, and there are 2 more people who will be speaking in the PxP Global Conference. So I urge you and everyone else also to be a part of those sessions. And see you. Maybe we'll do this again, something on this hopefully soon, and we'll see you again on that. And looking forward to actually working together with everyone. I hope this can actually result in some greater collaborations rather than just 2 people or 3 people collaborations. Since we are representing so many diverse domains, I hope that we can come up with something that involves everyone and take this cause forward. So thank you everyone. Have a good evening. And I think with that we can close the webinar.
Thank you.